Hello friends, welcome back to BGS Clinics. In this clinical class, I will discuss how to palpate cervical lymph nodes. It is essential to acquire this clinical skill as we frequently require to palpate these lymph nodes. You may recall what I said at the outset in the video on local examination. Local examination is never complete without examination of the surrounding area and regional lymph nodes. First, let us revise the anatomy of cervical lymph nodes, and then I will describe the clinical methods to palpate these nodes. By the way, do you know what is the size of a normal lymph node? It's as small as the size of a pinhead, that is just a millimeter in diameter. So, a normal lymph node is neither palpable nor easily visible. Any lymph node that is palpably enlarged is pathological. Although in most of the situations enlarged lymph nodes are a cause for concern, there are exceptions. That means in some cases, the enlargement is self-limiting and there is no need to investigate. I will discuss all that in a dedicated video on lymph node swelling. Cervical lymph nodes are classified using two criteria: their topographic placement and the anatomic plane in which they lie. Topographic placement is discussed with respect to various triangles of the neck or specific anatomical regions like parotid, for example. The neck is divided into two broad triangles by sternocleidomastoid and trapezius. The anterior triangle is bounded by the anterior border of sternocleidomastoid, mandible, and the midline. And the posterior triangle is bounded by the posterior border of sternocleidomastoid, the anterior border of trapezius, and the middle third of clavicle. The main anterior triangle is further subdivided into four smaller triangles, namely the submental, submandibular, carotid, and muscular. The boundaries of submental triangle are described in two different ways by different authors. One group of authors describes the boundaries as the anterior belly of digastric, the midline, and the body of hyoid. The other group describes them as the anterior belly of digastric of each side and the body of hyoid. This way of defining the boundaries suits us, the clinicians, better. Submandibular triangle, also called digastric triangle, is bounded by the mandible and the anterior and posterior bellies of digastric. Carotid triangle is bounded by sternocleidomastoid, superior belly of omohyoid, and the posterior belly of digastric. As the name suggests, the most important critical structure it contains is the carotid sheath. The posterior triangle is subdivided into two smaller triangles by the inferior belly of omohyoid. The upper one is called occipital triangle and the lower one subclavian triangle. As far as the anatomical planes occupied by cervical lymph nodes is concerned, the nodes lie either in superficial plane, which is subcutaneous, or deep plane, which is deeper to the investing layer of deep cervical fascia. Why is it essential to know the anatomical plane in which the nodes lie? Well, while performing excision biopsy of lymph nodes, you must know how many layers you need to cut step by step from skin downwards before you reach the desired node to be excised. So many times I see surgeons, particularly postgraduate residents, struggling at a biopsy of deep-seated lymph nodes because they do not incise even the platysma, let alone the investing layer of deep cervical fascia. There are no lymph nodes in the skull. There are no lymph nodes in the face as well, except for a single buccal node lying on the outer surface of buccinator. Lymph nodes in the neck may be broadly classified as deep cervical nodes, which lie within the carotid sheath around the internal jugular vein to be precise, and all the remaining lymph nodes as the outlying nodes. The outlying nodes are disposed in two broad groups, transverse and longitudinal. The transverse group forms a ring or a pericervical collar located at the junction of the head and the neck. And the groups of lymph nodes in this ring are submental, submandibular, upper superficial cervical, preauricular, postauricular, and occipital. All these nodes lie in the superficial plane. Some of them, however, namely in the submental, submandibular, and preauricular groups, lie in the deep plane as well. The longitudinally disposed nodes lie along the external jugular vein. Most of them are placed in the superficial plane overlying the sternocleidomastoid, except for few along the terminal portion of the vein, and those are deep-seated. This is obviously because beyond the posterior border of sternocleidomastoid, the external jugular vein pierces the investing layer of deep cervical fascia to become a deep structure itself before terminating into subclavian vein. All the outlying nodes eventually drain to the deep cervical group of nodes. Three to four nodes lie beneath the chin in submental triangle. Half a dozen nodes lie in submandibular triangle. Most of them lie in the superficial plane and some are embedded in the salivary gland. Upper superficial cervical nodes, as the name suggests, lie in the superficial plane over the upper part of sternocleidomastoid. Preauricular, also called parotid lymph nodes, lie, as the name suggests, in parotid region, both outside and some embedded in the gland. Postauricular nodes lie over the upper part of sternocleidomastoid above the upper superficial cervical nodes. See, these are upper superficial cervical and these are postauricular. And then there are two or three occipital nodes lying in subcutaneous plane over the upper attachment of trapezius. They become enlarged in scalp infections and rubella. The deep cervical lymph nodes are divided into two groups. The so-called main group forms a chain along the internal jugular vein, mostly under the cover of sternocleidomastoid. That means topographically they lie in the carotid triangle. They are usually subdivided into upper and lower groups. Some authors, however, mention upper, middle, and lower. The lowest nodes in the lower group extend behind sternocleidomastoid into posterior triangle of the neck, forming the supraclavicular group, which contains numerous lymph nodes. The other deep cervical nodes include prelaryngeal, pretracheal, paratracheal, and retropharyngeal nodes. In the posterior triangle of the neck lie two groups, supraclavicular and multiple unnamed scattered nodes. Supraclavicular are named as such because they are situated topographically in the lower region of the posterior triangle called subclavian triangle. However, as I said earlier, they are actually the lowest nodes in the lower group of deep cervical nodes which extend behind sternocleidomastoid into the subclavian triangle. In addition, the nodes along the terminal segment of external jugular vein also contribute to this group. And then there are multiple unnamed scattered nodes lying between the roof and the floor of the posterior triangle. The roof is formed by investing layer and the floor by prevertebral layer of deep cervical fascia. Without a detailed knowledge of anatomy, it is neither possible to do a clinical assessment nor possible to operate confidently. Clinical assessment means physical examination, interpretation of findings, and drawing an inference. Moreover, if you look at the central axis of human body consisting of the head, neck, chest, and abdomen, the neck is the narrowest region. So many critical anatomical structures pass through it up and down, and interestingly, all of them are packed beautifully with provision of a perfect protection to them. For example, the carotid sheath is so well protected by the thick and strong sternocleidomastoid muscle. The point that I want to make is you may have to pay a heavy price if you commit even a small error while operating in the neck without having a detailed knowledge of anatomy. At this juncture, I would like to make a comment about the classification of cervical lymph nodes into some 6 or 7 levels. To compel students to memorize these levels is unnecessary. In my personal opinion, undergraduate students and postgraduate students of general surgery should use the basic descriptive anatomical terminology, like say submental instead of level 1A or lower deep cervical instead of level 4 and so on. The classification into levels may be used by oncosurgeons, oncologists and oncopathologists. Anyway, now let us see how to palpate the cervical lymph nodes. The basic clinical method of palpation is the same for all lymph nodes, with gentle rolling movements of fingertips. Now, fingertips do not literally mean the bang end on tips, okay? Slant the fingers slightly and palpate with the pulp of the fingertips. Stand behind the seated patient. Palpate one side at a time, especially the deep cervical group of lymph nodes, because cerebral ischemia may result if both sides are palpated simultaneously, compressing both carotid arteries. This makes the patient feel giddy and uncomfortable. Flex the head slightly, plus tilt it slightly on the side to be examined. This is to relax the muscles and deep fascia. Maintain this position by the other hand resting on the head to curb the natural tendency to extend the head back to original position. Palpate with rolling movements of pulp of the fingers. Palpate them in a sequence: submental, submandibular, upper superficial cervical, preauricular, postauricular, occipital, deep cervical, supraclavicular, and unnamed scattered nodes in the posterior triangle. And in occasional cases, the anterior deep cervical group of nodes may have to be palpated, namely the prelaryngeal, pretracheal, and paratracheal. It's not difficult. See, most commonly you got to palpate 9 groups in 3 areas: the transverse pericervical collar, carotid triangle, and the posterior triangle. That's it. Flex the head slightly and also tilt it slightly on the side to be examined. Submental group of lymph nodes. Submandibular nodes. For this, hook the fingers gently under the mandible and try to push the nodes outward so that they can be more easily palpated against the medial surface of the body of the mandible. Upper superficial cervical, preauricular, postauricular, and occipital. Then proceed to deep cervical group of lymph nodes. Begin with the upper group first and then proceed lower down towards the lower group of deep cervical nodes. Supraclavicular and finally multiple unnamed scattered nodes in the posterior triangle. Repeat the same steps on the other side. To ease the palpation of deep cervical group of lymph nodes, retract the sternocleidomastoid muscle behind slightly. It is wrong to palpate both the sides simultaneously. Palpate one side at a time. There is one more technique for palpation of supraclavicular nodes. Stand in front of the patient, ask the patient to lock the arms and flex them together. Now that deepens the hollow of supraclavicular fossa. Feel for the nodes therein with tips of your fingers. So that's it about palpation of cervical lymph nodes. Thanks for watching.